Hello ladies and gentlemen. My today's video is about history taking skills for Plab 2 stations. My name is Dr. R-jalal. I have already made 6 videos about essential communication and interpersonal skills for Plab 2 exam, and this video is about history taking skills. There are 3 areas which are assessed during Plab 2 examination. The most important one is interpersonal skills and communication skills. Second is data gathering, which includes history taking and examination plus investigations. And third area in which you have to perform during your Plab 2 examination is management, how you manage your station. After this video, I intend to make another video about management skills. My aim is to help others who are preparing for Plab 2 examination from my own experience and what I have learned during my course of preparation for Plab 2 exam. So let's start. First question is why we take history from a patient. Almost all of us know that we take history to reach the diagnosis and to exclude differentials, especially serious and life-threatening conditions. But the aim and reasons are much beyond this, just making a diagnosis. So other reasons to take history include identify the risk factor, find out comorbidities by systemic review, find out any complications, and to find out side effects or drug interactions, to find out what is in the patient's mind by exploring eyes. This is very important reason to take a history. Another important thing is that to find out how illness is affecting the patient's life at home, at workplace, and in general, and to find out the exact needs of the patient. So the ultimate aim is to collect all necessary and relevant information to make an individualized management plan for our patient. To take a good history, you must know what is the framework of a good history. So a general framework for history taking is that you should start with grips, and I will discuss about grips in a while. Then presenting complaint, history of the presenting complaint, which also includes asking about investigations, treatment, and referrals already arranged and provided. Systems review, which includes asking important relevant questions about cardiovascular, respiratory, gastrointestinal, nervous system, musculoskeletal system, genitourinary system. Next is taking past medical history about significant past diseases, illnesses, surgery, including complications of surgery and any trauma. Past medical history should be relevant to the presenting complaint. Medication history, medication which patient is taking now or had been taking in the past. Medication history also include prescribed and over-the-counter medications, including food supplements. Very, very important is history of allergies to medicine, especially to penicillin and to food. Next comes family history, especially parents, siblings, and children, which means blood relations. Travel history is also important in many cases. Social history, which includes lifestyle history, including smoking, alcohol, recreational drugs, accommodation and living arrangements, partner and sexual history, baseline functioning, especially in elderly patients, then occupation, pets, and hobbies. All this is included in social history. Don't forget to ask about anything else. Ask the patient, is there anything else which patient wants to tell you? And in female patients, don't forget to ask P5 questions, that is periods, pills, pregnancy, pap smear, partner, and also you can include breastfeeding history. In pediatric patients, don't forget to ask bird questions, which include birth history, immunization, about Red Book, and developmental milestones. And finishing your history by saying thank you to your patient. Thank you very much for all the information. So this is the basic framework of a structured history which you should follow, in which you must follow in your examination. But keep in mind that you should ask about relevant questions, not just asking about everything. Now I am going to discuss important tips for a good history, which is the art of history taking. As I have mentioned so many times that the basis of a true history is good communication between doctor and patient. It is important for doctors to acquire good communication and good consultation skills. Second important thing is that you should allow the patient to unburden himself or herself. They may be upset about their condition or with the frustrations of life, and it is important to allow patients to give vent to these feelings. Conduct a patient centered consultation by showing appropriate empathy, sympathy, and understanding of the patient's concerns. A very important tip for a good history taking is that try your best to identify the actual issue in that station. The patient may not be looking for a diagnosis when giving their history. The patient's problem, whether it has a medical diagnosis attached or not, needs to be identified. The most important thing is to recognize the issues and then prioritize them in your consultation. This is very, very important point. Now coming to grips. Grips, I will discuss it in a bit, but you need to develop rapport and show sensitivity for the patient's feelings and concerns, including use of stock phrases. You should always use stock phrases that show that you are sensitive to the patient as an individual. Another important tip is that don't use closed or leading questions in the beginning of your consultation. Start with an open question. You can ask, how can I help you? Or what brings you here today? If the presenting complaint is distressing, say I am sorry, but not for common day-to-day problems. And then ask, tell me more about it, how and when it started. Another very important criteria is which is assessed by the examiner is that whether you ask questions which are jointed together, which are linked with each other, and they are consistent and follow a reasoned thinking which takes you towards a diagnosis. You can use closed questions when you are going to exclude red flags. ICE. ICE is very important. A good history is one which reveals the patient's ideas, concerns, and expectations, as well as any accompanying diagnosis. So, ICE is very important to know what is in your patient's mind. Without the patient's perspective, the history is likely to be much less revealing and less useful to the doctor who is attempting to help the patient. Another important tip is that pay full attention to the patient's agenda, beliefs, and preferences. Your consultation should be patient centered. So pay full attention. What is in patient's mind? What are their beliefs and preferences about their illness and treatment? Listening is a very, very useful and critical skill which you have to show during your exam. Listening is at the heart of good history taking. Guys, don't forget this. When you ask a series of questions, also listen to the answers. Reflect and act on them, not just listen and ignore. During history taking, it is very essential that you pick up cues and make adequate use of these verbal and non-verbal cues. Don't just ignore non-verbal cues and your language. It should be simple and understandable to the patient according to their age, according to their uh, ability, according to their age, according to their IQ level, according to their education. And never ever forget to check understanding. During your consultation, patients may ask you about different things, and you will have to explain these things. But your explanation should be good. And a good explanation is which is short, which is to the point, which is relevant, and which is complete and polite. Use words such as fortunately, your all test results are normal, or unfortunately, this disease is not curable. So give explanations which are short, to the point, relevant, complete, and polite. Avoid medical jargons. Avoid abstract phrases, especially with people who have learning disabilities. And avoid speaking too quickly for the patient to take in what you are saying. Few more essential tips: never show disinterest, even if the patient is talking nonsense. And never interrupt your patient directly. Wait for the pause and then say, "What about if we first talk about," and then bring him back to the important points in the history, rather than interrupting and snatching words from your patient's mouth. Another area which you will be assessed in your exams is whether you criticize or judge your patient. Don't even raise an eyebrow. Never criticize or judge your patient. Another important thing, which is very, very essential skill in counseling stations: don't push or force your patient. Only give suggestions, options, and recommendations. Tell them pros and cons, then leave the decision with the patient. Now, few other important uh, history taking skills which which you should keep in your mind. Signposting. During a consultation, a patient needs to understand what you are asking for and has to be able to follow your train of thought. In order to provide structure during the consultation, it is important to signpost. A signpost is an explicit statement used to inform your patient what you are about to say or do. Signposting may contain a rationale for the next step, or a brief introduction of the steps to be taken. Signposts are often used to transition or change directions during a consultation or before asking sensitive and personal questions. It makes clear to the patient what is going to happen, so the patient may feel less anxious and may have a greater sense of control. It will also put them more at ease, as they are provided with a structured account of the actions and questions to come. So, guys, signposting is very important. Another important tip is summarizing. After taking the history, it's useful to give the patient a rundown of what they have told you as you understand it. For example, "So, John, from what I understand, you have been losing weight, feeling sick, had trouble swallowing, and the whole thing's been getting you down. Is that right?" And if patients say yes, or there is a nod of approval or expressed agreement with the story, then it's fairly certain you are getting what the patient wanted to tell you. This is the benefit of summarizing. And last few tips: sharing understanding. It is always a good idea to ask the patient if there's anything they want to ask you at the end of a consultation. This can help you to impart further information if there's something they haven't understood, and it can reveal something that's been troubling them that hasn't been touched upon or got to the bottom of. It is an opportunity to confirm that a shared understanding has been reached between doctor and patient. This is very important question, and it will give you extra information. And at the end, try to seek an agreement to your management plan by asking, "Is that okay? What do you think? And what is your opinion?" So, I just want to recap the main points. The main learning points of history taking skills are: try to let patients tell you their story freely. When you use questions, try to keep them as open as possible. Use all your senses to listen, and keep an open mind, and always ask yourself if you are making assumptions. And be prepared to reconsider the causes of symptoms that you or a colleague of you have decided upon. After describing these main points, I want to share with you a very, very important thing, which is the 10 feedback statements by the GMC, which the GMC examiner give in descriptions of feedback statements, and you will receive for each stations in your Plab 2 exam results. And I am going to describe negative feedbacks which you might get if you couldn't perform well in different aspects of your Plab to exam stations, such as consultation, issues, time management, findings, examination, diagnosis, management, rapport building, listening, and language. So let's discuss. About consultation, the GMC feedback may say that it was disorganized or unstructured because it includes illogical and disordered approach to questioning. You did not demonstrate sufficiently the ability to follow a logical structure in your consultation. For example, your history taking may have appeared disjointed, with your line of questioning erratic and not following reasoned thinking. You may have undertaken practical tasks or examination in an illogical order that suggested you did not have a full grasp of the reason for completing them or a plan for the consultation. Feedback about issues. You are not able to recognize the issues or priorities in the consultation. For example, the patient's key problem or the immediate management of an acutely ill patient. You didn't recognize the key element of importance in the station. For example, giving health and lifestyle advice to an acutely ill patient. About time management and findings. The candidate shows poor time management. You showed poor time management, probably taking too long over some elements of the encounter at the expense of other, perhaps more important areas. About findings, does not identify abnormal findings or results or fails to recognize their implications. You did not identify or recognize significant findings in the history, examination, or data interpretation. Feedback about examination, diagnosis, and management. The candidate does not undertake physical examination competently or use instruments proficiently. About diagnosis, the candidate does not make the correct working diagnosis or identify an appropriate range of differential possibilities. About management, does not develop a management plan reflecting current best practice, including follow-up and safety netting. About rapport building, the candidate does not appear to develop rapport or show sensitivity for the patient's feelings and concerns, including use of stock phrases. You did not demonstrate sufficiently the ability to conduct a patient-centered consultation. Perhaps you did not show appropriate empathy or sympathy or understanding of the patient's concerns. You may have used stock phrases that show that you were not sensitive to the patient as an individual or failed to seek agreement to your management plan. About listening and language. The feedback may be the candidate does not make adequate use of verbal and non-verbal cues. Poor active listening skills. You did not demonstrate sufficiently that you were paying full attention to the patient's agenda, beliefs, and preferences. For example, you may have asked a series of questions but not listened to the answers and acted on them. About language, does not use language or explanations that are relevant and understandable to the patient, including not checking understanding. The examiner may have felt, for example, that you used medical jargon or spoken too quickly for the patient to take in what you were saying. So, the purpose of all sharing all these information with you is that you should keep in mind what the GMC and Plab examiners are expecting from you when you perform during a Plab 2 examination station. You need to keep all these things in your mind if you want to pass your Plab 2 exam with good scores. So after discussion about what are the component of history taking and what are the criteria of good history taking, next step is how to remember all these things. So how to remember structure of history. There are mnemonics for history taking. These are very useful. You can keep these mnemonics in your mind to take a structured history. But of course, for interpersonal skills and communication skills, you have to learn about those and practice with your colleagues to harness those intercommunication skills before your exams. So to start a consultation, you can use GRIPS. GRIPS mnemonic stands for greetings, rapport, and introduction and identity check. So about greetings, greet according to the situation, say good morning or good afternoon, but not in breaking bad news stations or in cases where the patient is in distress. In such cases, just say hello. About rapport, you have to maintain good eye contact in the beginning of your consultation and throughout, and attain a friendly and attentive manner. Be aware of your posture, gesture, tone of voice throughout your consultation, and check patient's comfort and respond if patient is in pain or distress. Politely introduce yourself. I am doctor and your name, surname, and I am a junior doctor in this department or in this practice. And then ask patient, may I ask your name and age, please? After that, ask how may I call you. Then P in GRIPS stands for purpose of consultation and privacy. You need to explain to the patient what is the purpose of today's consultation and ensure that I will take care of your privacy. Then social courtesy, you need to be kind, nice, polite, very humble and respectful by your expressions, gesture, tone of voice and choice of words, and take permission to start history and appropriately use please, thank you and sorry. And whenever asking questions, always say, please, can you tell me? Would you like to tell me? And appreciate the patient during the consultation. It's a good thing that you have come for medical attention, or it's good that you have sorted medical attention. Another mnemonic is Socrates for pain, explode pain. For pain assessment, you need to use Socrates. S is for sight and severity of pain. And also, along with the asking about sight, ask does it move or radiate anywhere? Do you have pain anywhere else? About severity, you need to ask how bad is the pain. Then about onset and duration, O stands for onset, and I have included duration in it as well. When and how did it start, suddenly or gradually, and for how long does it last? C stands for character of pain. You can add continuity of pain and course of pain in this. So what is the pain like? Is it continuous or intermittent? It is progressive or regressive? And is it getting better or is it getting worse? R in Socrates stands for relieving factors. Does anything make the pain better? A stands for aggravating factors. Does anything make the pain worse? T stands for timing. Does the pain follow any pattern, any time of the day? Then E stands for extra feature, any other signs or symptoms associated with the pain. And S stands for similar episodes in the past. Next mnemonic for history taking is OD para. This is for exploring other symptoms. Onset is O stands for onset, when and how did this start? Duration is for D for duration, for how long or since when. I stands for intensity of the symptom. P stands for progression, whether it is increasing or decreasing, continuous or intermittent, comes or goes. A for aggravating factor, R for relieving factor, A for any other symptoms associated with it. The time course is not is mistakenly written in this. It is not included in ODPARA. Sorry about that. And to complete the rest of the history, first you have to ask about other systems. So systemic review, don't forget this. Ask about one or two relevant questions about cardiovascular, respiratory, gastrointestinal systems, nervous system, musculoskeletal system, genitourinary system, and any rashes or skin problems. You need to ask relevant questions, keeping in mind the presenting complaint of your patient. To complete rest of the history, then is P maftosa. This mnemonic is also very essential. So P is for past medical and surgical history, including any hospital admissions and any complications of the treatment. Medication history, patient medication which patient is using now or has been using in the past. About allergies to medications and food, particularly to penicillin. Family history relevant to the presenting complaint. Travel history, occupation and occupational history. Ask whether patient has the same occupation throughout his life or has he changed the occupation. Then social, sexual and lifestyle history, and A stands for anything else. So P maftosa, you have to explore other areas in your patient's life. As I discussed in the beginning, history taking in females, remember P5 mnemonic for female patients to ask specific questions in case of females. P is for periods, ask about last menstrual period, regularity of periods, whether they are painful and any intermenstrual bleeding. Ask about pills or any other contraceptive method they are using. Ask about pregnancy, previous pregnancies, any miscarriages, and any ectopic pregnancy. Ask about pap smear, especially when was the last pap smear done and what was the result, and partner history, sexual orientation, whether partner is male or female, and about the nature of the relationship, stable relationship or not. In pediatric patients, mnemonic is bird. The rest of the structure is same, but you have to ask bird questions. B stands for birth history, I stands for immunization history, R stands for red book, and D stands for developmental history. You can also add nutrition and feeding history. Another mnemonic which I have discussed in the during my previous slides, this is ICE. This ICE is used to know what is in patient's mind. So ask the patient, do you have any idea what might be causing your problem? What do you think might be going on? Are you particularly worried about something? Do you have any questions in your mind? Do you need any clarification at this point? Is there anything you may have thought we could do for you today? What are you hoping from today's visit or consultation? And what are you expecting from us today? Do you have any idea about what should we do to help you better? Or is there anything you want to discuss with us in particular, which we haven't touched up till now? In case of psychiatry history, mnemonic is ABSMC 4 FEM shit. So what does it mean? A stands for appearance of your patient, B for behavior of your patient, and S for speech of your patient. You need to observe these. You don't need to directly ask these from your patient. Then M stands for mood and C for concentration. You need to check these. 4F is for family, friends, finances, and forensic. Forensic mean any trouble with the law. A stands for alcohol and recreational drugs. M is for medicine, other mental health issues or medical conditions. S stands for suicidal thoughts. H stands for hallucinations. I stands for insight, whether patient is aware about his or her mental health issue and whether the patient is willing for treatment or not. And then thoughts, especially important in history taking from a patient with psychotic features. Another important mnemonic is SIGI-CAPS for depression symptoms. This is to ask about criteria A symptoms of depression, and it stands for sleep, interest, guilt, energy, concentration, appetite, psychomotor agitation or retardation, and suicidal ideation. For a patient with depression, you need to ask about loss of sleep, loss of interest, feeling of guilt, lack of energy, lack of concentration, loss of appetite or increased appetite, psychomotor retardation or agitation, and suicidal ideation. Very, very important. Now, some mnemonics about alcohol and drug addiction history. Remember KH and TDW questions for alcohol and drug addiction stations. C for cut down, ever try to cut down. Annoyed, gets annoyed when someone talks about addiction. Is guilty or not. E for early morning, first thing in the morning to take alcohol or drug to keep going or start working. And TDW questions are tolerance, using increased dose for the same effect, dependence, and withdrawal symptoms. So very important, KH plus TDW for alcohol and drug addiction scenarios. Another mnemonic, PDA plus 4 famish. This is scenarios where patient has attempted self-harm or suicide. What is BDA? BDA is for elaborating the actual event. So B is for what happened before the event. D is for what happened during the event. And A is for what happened after the event. So BDA. And what is famish? Famish is 4F. Family, friends, finances, and forensics. Ask questions. How is your current social support? How are things with your family? Do you have many good friends? Are you currently in financial trouble, or are you working or not? These are all risk factors for suicide or self-harm. Have you ever been in trouble with the law? A stands for alcohol and drugs. Do you normally consume alcohol? If yes, elaborate. Do you take any recreational drugs? If yes, elaborate. M for mood, medications, mental and physical illnesses. How is your mood nowadays? How would you grade your mood? 1 being the saddest and 10 being the normal you normally have. I stands for insight and judgment. Do you know why you are in the hospital? How do you feel about life at the moment? How does it feel to be alive? Do you regret or feel angry about what you did? Would you try it again? How do you feel about the future? And do you have any plans for the future? How do you see the future? You can ask these questions by paraphrasing in different way. And do you need any help? This is to check insight and judgment of your patient. And S is to explore suicidal thoughts. Is not worth living. Did you ever wish it would end? Have you thought about ending it? Have you tried this before? And have you thought about how you would do this? Did you keep having thoughts or keep making plans? And did you make arrangements and take care of your affairs? Next is H is for hallucination and thoughts. Have you ever had experiences of hearing noises or voices when there was nobody around? Are your thoughts actually taken out or sent out of your mind? Do there seem to be thoughts in your mind which are not your own, which seem to come from somewhere else? Do your thoughts seem to be somehow public, not private to yourself, so that others can know what you are thinking? And note signposting is very important before asking about sensitive questions about hallucination and thought problems. You can say that I am going to ask you some general questions, some routine questions which we ask from everybody. Some questions might relate to you, some might not. So please bear with me. And this BDA you should also use in false and fits scenarios, because you need to elaborate the event by asking what happened before the event, during the event, and after the event. Make this a habit to ask in false stations, in fits, and in any suicidal or self-harm station. What happened before the event, during the event, after the event. And at the end, I want to give you some bonus tips for Plab 2. First one is when there are more than one symptom, patient comes with one presenting complaint and then there are some associated symptoms. When you explore more than one symptoms, explore the main symptoms in details by Socrates or Odipara, but for the other associated symptoms, ask only the most relevant questions. Don't go into detail. For example, if fever is the main symptoms and cough and associated symptoms, ask only necessary 1 to 2 questions related to cough, such as onset and phlegm. And about phlegm, ask only color and blood in the phlegm. And while exploring the associated symptoms, ask questions about serious conditions first, such as for fever and headache, ask about neck stiffness and photophobia to exclude meningitis. And in case of fever plus cough, ask about pneumonia symptoms, such as phlegm, shortness of breath, and chest pain. So when asking about associated questions, you need to ask only 1, 2, or 3 relevant questions, and those questions should be about serious conditions first. And and some interesting thing about Plab 2 exam, that it is a strange exam. You may fail the station which you think you have done very well, and the station you think you didn't perform well, you would pass. One good point can pass, and one bad point may fail you. For example, memorize scripts give a very bad impression and can lead to your failure. Similarly, if you talk non-stop and just repeat the notes which you have read, then the examiner will penalize you. Try to be as natural as possible and don't follow your notes in the exam. The golden sentences for Plab 2 which you must remember, that the more expert you are in acting, the more chances you might pass. The better communication skills you have, the more chances you might pass. The more knowledge you have, the less chance you might pass. It might sound you strange, but it is true. In more than 50% stations, there is no medical knowledge involved. And if involved, it is your basic foundation year 2 level knowledge. So please, guys, don't follow scripts, don't be robotic, apply your knowledge according to the situation, and practice your interpersonal and communication skills. Thank you very much. And this is the end of my this video. Thank you for watching, and don't forget my other videos about interpersonal and communication skills. Subscribe to my channel and tell your friends as well. Press the bell icon for more interesting videos. And thank you very much. See you again next time with another interesting video. Bye bye.